This is a Beggy Sisa podcast.
Up to 80% of patients have a family history of a first-rank family member, so a sibling or a child or a parent that do have ADHD. But 20% of people have no family history. Together with genetics, the other big risk factors for ADHD is obviously complications during pregnancy, of which the biggest one is prematurity. So children that is born prematurely, and I'm talking about significant premature, not 1 or 2 weeks, they do have a higher risk for the development of ADHD.
Hello and welcome to this podcast. I'm Mia Malan. We're going to look at a condition that affects your ability to concentrate and regulate your emotions. 8 in 10 cases of attention deficit and hyperactivity disorder, or ADHD as we all know it, are genetic. So what should you do if you think you or your child may have ADHD, and where should you go for help? In this 2-part podcast on ADHD, I speak to Renata Skuman, a psychiatrist based in Cape Town who chairs the ADHD group of the South African Society of Psychiatrists. Renata is also the co-author of South Africa's guidelines on how to manage ADHD. In this first part, we're going to find out what ADHD is and learn more about the science behind it. In the second part, we'll focus on the medicine used to treat it. Renata, thanks for joining me today. How common is ADHD in South Africa?
Mia, there's the real statistics, international statistics, and then there's often public perception. If we look at the international data, we found across countries, across social strata, across cultures, that the prevalence of ADHD in school-age children is between 5 and 16%, and in adults between 3 and 4%. However, in South Africa, we do not have those level of detailed statistics. We have done extrapolations, which would be the same then if you look at roughly 3 to 4% of the adult population, which makes it that it's more than 1 million South African in the adult population affected. However, what we see in community-based samples, especially in underprivileged communities, is that it is really not diagnosed yet. And we have a prevalence of less than 2% in the public sector, and we know that that doesn't reflect the real case. But then there's also pockets of the population in the more privileged areas, and especially around privileged schools and privileged universities, where the presumed prevalence rate is way higher, but that might not reflect the true prevalence, but rather accessibility to mental health care and medication.
How do you know if you've got ADHD?
ADHD is a neurodevelopmental disorder which is present across your lifespan. So if you really go back into a detailed history, we can pick up symptoms and signs from early childhood, even preschool years, which affect you throughout your lifespan, but in various ways. The most important symptoms that you need to have is a combination of what we call the core triad of ADHD, which is inattentiveness, hyperactivity, and impulsivity, and you need a number of those symptoms. But together with that, we often see emotional dysregulation. It's not only something that happens during exam time or when you have to study, but it's present in your personal life. It's present at home. It is present at work or school as well. And then the other very important thing is that it has to cause functional impairment. So you might struggle to concentrate today or be very distractible, but if it doesn't really impair your academic or occupational functioning or create emotional difficulties such as secondary anxiety or depression, or really causing social difficulties and difficulties with your peer group or social interactions, then it is most likely not ADHD.
So if I'm a parent and I suspect my child has ADHD, what do I do? Do I go to psychiatrist? Do I go to the GP? Who can diagnose it?
I would say a good starting point is speaking to the teacher. What do they experience? Because often what we see at home is not necessarily how our child function in a different setting. Many schools do have support available at school, maybe a counselor or a psychologist, but especially in the less privileged areas, I would say a good starting point is either a psychiatrist that's well versed in ADHD or an educational or clinical psychologist. I would be hesitant, especially in a child, that the first point of call is a general practitioner. Especially in children, we have to distinguish for other reasons that can, again, present with symptoms suggestive of ADHD.
So if the parent then does speak to the teacher, what is the sort of typical feedback that a parent would get if the child does have ADHD? What kind of behavior would that teacher describe?
The child can present with academic, behavioral, or emotional difficulties. If we look at the behavioral difficulties, the teacher might say that your child is disruptive, or the child is speaking out of turn, or if a friend bump by accident against the child, that there's quite an emotional reaction and a big bump back. So there's sometimes that behavioral impulsivity and hyperactivity that is noticed. If we think more about the inattentiveness, the teacher might say that your child is staring out of the window, or I must often try to bring her back to the classroom, or call her name, or just tap her shoulder to pay attention again. She might struggle to finish her work, or the quality of the work might wax and wane. Good quality work the one day, doing well in the assessment, the next day it's really just not going well. And you will see that the homework escalates because they don't complete the task in class. The third thing that we see is maybe the more emotional difficulties, that it might be that a child struggle with self-esteem, they don't have the confidence to speak in class, to raise their hand. It might be because they miss some of the information. And the other thing that we often see where children come to our attention is where a teacher might alert the mother or the father that there's problems with the peers. The child is not selected to be part of the group or the team, or excluded or teased. Often because of the social inappropriate behavior, the child doesn't always read the social circumstances very well.
Is there a test that a child does that you can use to diagnose them, or is it just observations of behavior? How does it work?
It's a little bit of a misconception that there's a test that we can do. And often people do a rating scale and say, oh, my child has ADHD. We do not use rating scales or symptom checklist as a diagnosis, because that symptoms, it can be an indication of ADHD, but there's many other conditions that can have the same symptoms. So there's various rating scales that I don't want to use their names necessarily now, that you can do as just what we call a screening instrument. Is this possible ADHD? And those instruments are good. It's a good idea if the parents complete one and maybe the teacher complete one before you go to the healthcare professional, but there isn't a test. We must also know that even if you start with the educational psychologist that do a batch of tests then to distinguish what is going on. Again, about 10, 15 years ago, it was quite common that a test would maybe show there's a discrepancy between verbal and nonverbal IQ, and then that test would be taken to a GP and a GP would start medication. If that is the case, it's often rather another learning disorder. So we look at the behavioral assessment during those tests as well. There's also no brain test. You can't do an EEG, you can't do a blood test, you can't do a scan in clinical practice. That is really reserved for research purposes. So when we diagnose a child or an adult, we carefully take a full developmental history.
Just as a matter of interest, you've mentioned now that you can't do a brain test. Is it because it's too expensive? And that if you do a brain scan during research, would someone with ADHD's brain look different than someone without it?
In a clinical environment, yes, it is just not accessible and affordable. But if we look in the academic environment and in the research environment, and why we know that ADHD is a scientific disorder, there's more than 10,000 publications that clearly establish differences between someone with ADHD and without ADHD. And the test that specifically shows differences in how the frontal lobe operates, so there's less executive control, and also difficulties with judgment, planning, organization. So we can do functional imaging, what we say, the person in the scanner, and you give them certain tasks to do, and the brain light up differently. We know that there's this regulation of dopamine and noradrenaline, specifically in the frontal lobe. There's even structural differences. The other thing that really, really complicates the matter is that there is comorbidity often present. So depression, for example, can also lower dopamine. So now you do a brain scan, and what does it show? Lower dopamine. But you can't distinguish then really what is first, the depression or the ADHD-like symptoms. And that's where the clinical interview is so important.
You've mentioned dopamine now. How does that play a role in ADHD? How does it work when it's not regulated?
To really simplify it, we are specifically interested in dopamine and noradrenaline, but I will touch on serotonin as well. Dopamine make it possible to concentrate on the task at hand. So dopamine helps you to listen to my answers, for example, now. or it also have a strong, important role in motivation and drive and energy. So to get going, we get often people with ADHD that's quite sluggish or procrastinators or slow to get out of the blocks. And that's the dopamine effect. Noradrenaline has more to do with drowning out the noise. So while you talk to me, you don't necessarily hear the traffic outside, you don't hear the buzz of the aircon, you are really able to drown out the noise. And those two neurotransmitters is also then predominantly where the medication for ADHD is focused on targeting. However, more recent studies also showed us the importance of serotonin, especially for emotional regulation and then also for the regulation of impulsivity.
Now, Renata, what causes these things to be out of balance?
The main thing that we know is it's a very genetic condition. Up to 80% of patients have a family history of a first-rank family member, so a sibling or a child or a parent that do have ADHD. But 20% of people have no family history. Together with genetics, the other big risk factors for ADHD is obviously complications during pregnancy, of which the biggest one is prematurity. So children that is born prematurely, and I'm talking about significant premature, not 1 or 2 weeks, they do have a higher risk for the development of ADHD. And then once again, it's a interaction between genes and maturity of the brain, where we can find that certain neural migration pathways are different than in a brain without ADHD.
Now, we've spoken about children with ADHD and how a parent can recognize some of the symptoms and then look for help. But what about adults? How do you get through life and then you only discover when you're an adult you've got ADHD? How does that work?
So there's a few things that play a role. It depends on when you were born. 40 years ago, ADHD was not a very well-established condition, maybe internationally, but not so much in South Africa. So back in the days, you most likely would be the guy that was the runner. You were sent out of class when you misbehave or to go and run off your energy. Now you're an adult. You might be a parent. Your child is diagnosed with ADHD. And during the assessment, you listen to this, and I often see how the parents start to look at each other and think, but that's me, or I recognize that symptom. So often we see that the pathway diagnosis is actually via the child, when the parents become more informed and understand that what they experience at childhood is maybe also ADHD that was not diagnosed. The second thing that we see in adulthood is often the people with real ADHD don't necessarily come to you with, "Doctor, I think I have ADHD." We more commonly see people with depression or anxiety disorders that doesn't respond to treatment. It's difficult to treat. And then when we really go back in the developmental history, we start to recognize, but well, there's underlying ADHD. And if you don't treat that, life will always be more difficult. Because there's clear challenges that you might have, and you have to work so much harder, and it affects your self-esteem, etc.
So let's move to the other side. Can you outgrow ADHD? Can you have it as a child and then when you grow into an adult, it disappears?
Yes. And I say yes, with some reservations. So the research shows that about 60 to 70% of children can outgrow ADHD. And it has to do with the maturity of the brain. We know that the brain still mature up to the age of 23, before the frontal cortex is really fully developed. That's why you don't get your driver's license at 14, for example, and you should maybe not get it at 18. But we know that the brain matures up to 23, and then often the frontal lobes, where the judgment, planning, and insight is, and which regulate our executive functioning, is better developed, and then the symptoms of ADHD attenuate. The second thing is, if we diagnose ADHD early enough and a child get proper treatment and they get the necessary therapeutic support, they can develop skills. So they might still have ADHD as an adult, but because of them being really good with the skills that they've learned, being really good with self-care, routine, exercise, and doing all the other things, they are able to manage the symptoms of ADHD without necessarily having medication. And then we would talk about ADHD in remission or subclinical ADHD, where you don't necessarily need treatment anymore. Does it completely disappear? I have my reservations about it. If we look, for example, at someone that had an eating disorder earlier in life, your vulnerability to have an eating disorder later in your life is always there. And I think in ADHD, you might be symptom-free, but you might be later in your life again in a position. Maybe you get a promotion, or maybe you've been in a very operational position where there was very much a lot of structure which help you to function. You're now in a more strategic position without any structure, and then the symptoms becomes more prominent again due to the different context of work that you have.
That was Renata Skuman, a Cape Town-based psychiatrist with a special interest in ADHD. Join me for the second part of this two-part podcast, in which we'll find out how ADHD medication works and what it can and can't do. Until then, I'm Nia Malan. Go well.
This was a Peggy Sisa podcast.